So, welcome to this series of case presentations where we'll be going with common symptoms, but when we work up the case, we'll be going into a relatively rare diagnosis. So, let's start with the presentation. Myself, Devi Krishna, a final year MBBS student of 21 batch. Dr. Namita helped me with this presentation. So, it's a 41-year-old female from Trichy, teacher by profession, married, she has one child, no known comorbidities. She presented with lethargy and increased fatigability for 4 months, aggravated since the past 1 month, increased pigmentation over the face and trunk for past 3 months, loss of appetite, loss of weight of 5 kgs over 3 months was present. Other relevant history would be she is vegetarian since childhood, she has normal menstrual cycle, no family history of carcinomas, no history of TB, no history of photosensitivity or other allergies, no history of joint pain or oral or genital ulcers, but there's a significant history of chronic anemia where she said to had iron deficiency as well as vitamin B12 deficiency, and she took treatment for 1 month. From history and presentation so far, we could narrow down into it could be anemia, which is to be evaluated probably for vitamin B12 deficiency. It could be TB, it could be autoimmune disease, or any GI malignancy. We also need to rule out hypothyroidism or vitamin D deficiency. On examination, she is conscious, oriented, moderately built and nourished, BMI of 23.4 kg per meter square. She is afebrile, pulse rate is 100 beats per minute. BP is on the lower end, that is 90/60 mmHg. Pallor is present. There is increased pigmentation of the face, lips and oral mucosa. This also to be highlighted. We did lab, and in that 3 significant values were noted. That is, hemoglobin was decreased, that is 10.2. MCV was also on the lower range, that is 64.3. Sodium was also reduced, 126 value, where normal is 135 to 145. So after these investigations, we could again say that it could be either anemia, where we have to evaluate for iron deficiency anemia. With consideration of hypotension, hyperpigmentation and hyponatremia, we need to rule out adrenal insufficiency. Anemia and hyponatremia, we also need to evaluate if there is any underlying malignancy. Hyponatremia, since hyponatremia is there, we also need to look for SIADH. Now, coming to anemia workup. So, we did anemia workup since in India, iron deficiency anemia is most commonly seen in women. We did a iron profile where we saw serum iron is found to be drastically reduced, which with a value of 21.9, where the normal is 60 to 170 microgram per deciliter. Transferrin saturation level was also found to be decreased, 5.253, where the normal for female is 15 to 50%. In peripheral blood smear, we noted that there is microcytic hypochromic anemia and no abnormal cells were found. All other parameters were under normal limits. Other investigations done was chest X-ray, which was found to be normal. Ultrasound abdomen, borderline splenomegaly with 11.5 cm was noted. 2D echo was normal. Mammogram found bilateral multiple fibroadenomas, and further follow-up was advised. Stool local blood was negative. Treatment given with current investigations was that she was given 500 mg of ferric carboxymaltose along with oral iron supplementation to combat the iron deficiency anemia. Vitamin D supplementation was also started. Further investigation, after 2 days, serum osmolality, urine osmolality and urine sodium was tested. Serum osmolality was found to be decreased, that is 268, where the normal range is 275 to 290. Urine osmolality was also found to be 277 and it is within normal range. Urine sodium was 54.6. ANA screen was also sent. MAN2 test was also done. From this, according to this chart, since she had hyponatremia, it is important that we need to evaluate the cause of hyponatremia. So therefore, according to this flow chart, the test which we did, that is 1, 2 and 3. So initially we measured serum osmolality. Over there we found that it was 268. So therefore it was hypoosmotic. Now next test which was done was we measured the urine osmolality and it was found to be above the, we need to see if it is greater than 100 or less than 100. It was 277. So therefore it was above, well above 100. So therefore we'll come to this part of the flow chart. Next we need to measure the urinary sodium and it was again 56. So therefore it is on the this side of the flow chart. Considering before our differential diagnosis, one of them was mineral corticoid deficiency, nothing but adrenal insufficiency. So therefore, we need to evaluate more further on it because somewhat the diagnosis is coming towards that direction. So we need to think what could be the underlying pathology or disease in this patient. So what changed the scenario? It was a photograph. This was the photograph before she came, well before her symptoms started. This was when she was admitted for evaluation. So here you could see that she looks healthy, she is moderately built, and over here her weight is reduced. But the most significant would be the pigmentation, the skin tone. That is, here you could see that she is hyperpigmented. So then, with the view that there is hypotension, there is hyponatremia as well as hyperpigmentation, we need to check for serum 8 a.m. serum cortisol. Now, why 8 a.m.? Because cortisol in our body usually has a physiological diurnal variation where it is more predominant or the levels are more elevated in the morning. So, therefore, 8 a.m. serum cortisol is to be done. When that was tested, it was found to be drastically low, that is 1.51. Now, for the 8 a.m. cortisol algorithm, this is the algorithm where we found that it was 1.51. So, we move into this direction of the flow chart and we could see that a adrenal insufficiency is confirmed. So, therefore, the next step would be to measure the ACTH. Okay, so but before that, now since we know it is adrenal insufficiency, we need to know is it primary or secondary. So therefore, we recheck the medication list which she had taken to see if there is any exogenous steroids, but there was no exogenous steroids. After endocrine consultation, again ACTH stimulation test was done. We saw the values to be 1.51. Next step we said was to measure the serum ACTH. It was found to be 184, which is drastically increased from the normal range, which is 7.2 to 63. So therefore, coming back to our flow chart, we stopped over here. So we could see that it is elevated. Elevated, we move into this direction and therefore primary adrenal insufficiency. Therefore, we got the diagnosis where the patients came with very vague symptoms of lethargy, hyperpigmentation, and from tests we saw that there is hypotension as well as hyponatremia, and therefore our diagnosis is primary adrenal insufficiency. Now, the patient was started on IV hydrocortisone, 50 milligram IV 8 hourly. Sodium became normal and blood pressure was normalized. Now, we need to find why did this patient develop primary adrenal insufficiency. For that, we need to, these are the causes, that is infection. TB is the number one cause in India. It could be either histoplasmosis or HIV. Autoimmune adrenalitis is most common worldwide. Worldwide. It could either be if there is any hemorrhage into adrenals or is it metastasis. A&E screen which we gave before came back negative. Anti-dsDNA reports were awaited. Anti-TPO was negative. Autoimmune polyglandular syndrome was ruled out because there is no alopecia, no vitiligo, because vitiligo is prone more to secondary adrenal insufficiency. ANA negativity, no mucocutaneous candidiasis. So, but the MAN2 test which we sent before came back positive with a level of 22.5 millimeters. Serology was negative, CT adrenal protocol was done, and bilateral adrenals were normal, no features of shrinkage or enlargement or any infiltration or hemorrhage. Then what should we do next? So therefore, right now our spectrum would be, is it isolated autoimmune adrenalitis? So therefore, we need to sort out endocrine crinology review, and it was they were advised to do 21 hydroxylase antibody test. Patient was discharged with oral steroids, tab hydrocortisone 10 milligram at 8 a.m. and 4 p.m. Oral iron and folic acid was also started, considering that she is a vegetarian and she had iron deficiency anemia. Planned review after 2 weeks with the reports. At review, that is after 2 weeks, report from lab came back as positive for 21 hydroxylase antibody. So this is so far about the case. Now let's have a glance at primary adrenal insufficiency. It is relatively less common, that is 2 in 10,000 people. 50% is autoimmune cause, 50% genetic with distinct enzyme deficiency. Other causes would be infection, that is most common, like we said in India, TB, hemorrhage, infiltration. Clinical presentation, usually these patients have a very vague symptoms. Now, we could classify the clinical presentation as caused by glucocorticoid deficiency, um, mineralocorticoid deficiency, and adrenal androgen deficiency. So, coming to first, that is glucocorticoid deficiency. There can be fatigue, lack of energy, weight loss, anorexia, myalgia, joint pain, fever, normocytic anemia, lymphocytosis, eosinophilia, slightly increased TSH due to loss of feedback inhibition of TSH release, hypoglycemia, which is more frequent in children, low blood pressure, which we saw here, postural hypertension, hyponatremia is also present. Next would be signs and symptoms caused by mineralocorticoid deficiency. Over here, abdominal pain, nausea, vomit, again very vague symptoms, dizziness, postural hypertension, salt craving because of hyponatremia, low blood pressure, postural hypertension, increased serum creatinine, hyponatremia, and hyperkalemia. Now, signs and symptoms caused by adrenal androgen deficiency would be lack of energy, dry and itchy skin, loss of libido in women, loss of axillary and pubic hair in women. Other signs and symptoms would be hyperpigmentation, which we saw in this patient. Now, just why does this occur? Because usually in primary adrenal insufficiency, there's a problem with the adrenal gland. So what happens is that because of this, there is increased ACTH as it does not act on the adrenals. Now this ACTH usually binds to the MC2 receptors, that is mineralocortin receptors, which is present in the adrenal gland. But since this is exhausted or this does not work properly, this ACTH has to go somewhere, right? So for that, it goes to MC1 receptors, which is present in the skin. So therefore, hyperpigmentation occurs. Now, then chronic adrenal insufficiency. Again, these present with non-specific signs and symptoms such as fatigue and loss of energy. The distinguishing feature of primary adrenal insufficiency is hyperpigmentation, which is caused due to excess ACTH stimulation of melanocytes. We saw the reason just before why. Now, acute adrenal insufficiency, which is adrenal crisis, usually seen in primary adrenal insufficiency after a prolonged period of non-specific complaints. Postural hypertension progress to hypovolumic shock. Mixed features of acute abdomen may resemble neurological disease. Now, diagnosis. For primary adrenal insufficiency, we need to do a set of tests, that is ACTH stimulation test, random serum cortisol, but it has limited diagnostic value. Once adrenal insufficiency is confirmed, then measurement of plasma ACTH is the next step. If it is increased, then it is primary adrenal insufficiency. In an appropriately low levels, then it is secondary adrenal insufficiency. Now, this again is the algorithm for the management of the patient with suspected adrenal insufficiency. First, we need to have a high clinical suspicion of adrenal insufficiency, as again, they come with very vague symptoms. Screening or confirmation of diagnosis has to be done. So just now we saw what are the tests to be done. Differential diagnosis has to be pointed out. but that has to be ruled out with various tests like ACTH and hyponatremia algorithm we saw. Then from them we could either say it is primary adrenal insufficiency or secondary adrenal insufficiency, and further management has to be done accordingly. Treatment. Acute adrenal insufficiency, immediate rehydration is very important. Bolus injection of 100 milligram hydrocortisone followed by 200 milligram hydrocortisone over 24 hours. Mineralocorticoid replacement can be initiated once the hydrocortisone dose has been reduced to less than 50. So glucocorticoid replacement, oral administration of 15 to 25 milligram hydrocortisone in 2 or 3 divided doses. Half of the daily dose should be administered at the morning time. Mineralocorticoid replacement, 100 to 150 microgram of fludrocortisone. Adequacy of treatment should be monitored through BP, serum sodium, potassium, and plasma renin. Adrenal androgen replacement is indicated if the woman if the woman has features of adrenal deficiency. Thank you. I hope